Hi, friends. It's Dr. Mary Gardner with Lap of Love. And today I have a special guest to talk with us about a topic very near and dear to my heart, which is geriatric onset laryngeal paralysis and polyneuropathy, which is a big mouthful. And so that's why we like to shorten it and just say GOLPP. And I've done a Facebook Live on this myself, whether it was just me. And I decided that this time around, I'm going to bring on a super duper expert who is joining us today, Dr. Bryden Stanley. Welcome.
Hello. Nice to hear you all.
I love it. Yes, we're going to be seeing more and more people. And when you come in the room, please chat to where you're from so we can see how far we're reaching. And look, there are a lot of initials after your name, Dr. Stanley. I have it popped up there. And I know that you're a boarded surgeon. And for those that don't understand, when we go through veterinary school, it's a couple of years. We've got Portland, Texas joining us. And then, so you did extra work on top to become a boarded surgeon. How many years is that?
So typically after you graduate as a veterinarian, if you want to specialize, you'll do an internship where you rotate through a whole lot of different types of disciplines. And that can be 1 or 2 years. And then you start it's quite competitive to get in. In fact, it's even more competitive nowadays. You start a 3-year residency program where you can actually concurrently do an additional degree if you want. And then after that, that's an intensive program of training in that discipline. And for me, it was in surgery of small animals. And after that, you take this 3-day, it used to be a 3-day examination for to become a specialist. And so that's basically, and that's when you're just starting, then you start really learning. Yeah, then you start really learning. Yeah.
Then you're sure. And so do you prefer soft tissue or orthopedic or both?
I only do soft tissue.
Only do soft tissue.
I mostly do upper airway and wounds and skin flaps, but I do quite a lot of abdominal and thoracic stuff as well.
I know.
A lot
Listen,
of reconstructive surgery.
I watched a video of you where you were talking about skin and wound repair, and I loved that when I was at university too. We had a really large burn victim, and we were doing sugar bandaging and skin grafts. It was just so amazing and fun to watch it kind of grow together. But I don't want to keep everybody waiting because today we have a very important topic to discuss. And I was telling you before we popped on, as an end-of-life care doctor myself, I would help. Our number one breed that we help with end of life is actually Labradors. We do see the majority of our cases are Labradors, and so many have mobility issues from arthritis or other reasons. But so often, also, I found that they had this laryngeal paralysis disease, and so I learned myself so much more about it just because of that. Look, we got people from Texas and New Jersey. Hello, everybody, and also my own dog. So just to tell everybody, I had my Doberman. I have to show off because he's super handsome, if you can see him. So my red Doberman named Duncan, when he was 10, he started to do this clearing of his throat. Now, Dr. Stanley, can you do the clearing throat sound? That was it. So, and I'm like, what is he doing? And so I brought him to the cardiologist to do a workup because I was concerned about his heart, which is a big problem in Dobermans. Turned out, though, that he had this laryngeal paralysis. So, Dr. Stanley, can you explain to us what this is and why are you so interested in it?
Absolutely. So, for years and years, we used to call this disease LAPA or just laryngeal paralysis. And in fact, for a long time, it was called idiopathic laryngeal paralysis. Mm-hmm. And then we did a study a few years ago because we knew that the main complication from this surgery to open up the airway was aspiration pneumonia. And we always attribute it to the fact that we're opening up the airway. But I was looking at some old anatomy texts and realized that the nerve that innervates the larynx, there's a very similar nerve that comes up and innervates the esophagus. And so I started a study where we followed out normal dogs of an old age and dogs with LAPA or laryngeal paralysis. So they were age and breed matched. We followed both groups of dogs out for a year after we did the surgery on the affected group. And we followed them out every 3 months looking at their esophageal function. So it's how their swallowing function. And at that time that we followed them out, we also did, complete examinations on them. And so what we were looking for was if the dogs that had laryngeal paralysis also had some swallowing issues compared to the group that weren't affected, that were the same age. And we found some really interesting things, some of which we didn't expect. The first thing we found was, first of all, they did indeed have swallowing dysfunction. So the dogs that have got laryngeal paralysis also have, they don't always have megaesophagus. In fact, they very rarely have megaesophagus, but they do have a degree of swallowing dysfunction just in the upper part of their esophagus. So that was an important finding. But because we were looking at these guys every 3 months and doing exams on them, we noticed that the dogs in the affected group, the dogs that had laryngeal paralysis, were also becoming weaker in their hind limbs, and they had delayed proprioceptive deficits. So they were becoming just mildly neurologic. And then some of them, by the end of that first year, became progressively neurologic. And so what we concluded from that first study was that this was a late onset. So in other words, geriatric onset. Geriatric means old. So geriatric onset, a late onset of not just laryngeal paralysis, but a generalized neuropathy. It's not painful at all, but that's why we called it GOLPP. It's geriatric onset laryngeal paralysis polyneuropathy. And so they, first of all, they start with sort of a little bit of swallowing, that sort of throat clearing problems. And then the laryngeal paralysis, which is, it starts off on the left and then goes to the right, and it's always
I didn't know that.
Yeah, always starts on the left. Yeah, the nerve's slightly longer.
Is it longer? That's why. Right. Okay. I remember that.
And so they have this, what we call stridorous breathing, and it can actually be so bad in many dogs that when they breathe in, they collapse their larynx down on themselves, the vocal folds and certain processes in the larynx, and they can asphyxiate. So this was really interesting. We found a number of, and it was a really, really in-depth study. We tested them eating on kibble and on soft food and on water, or liquid. Nice. And so we found out a number of things, and one of them is that when we manage them to do their tieback, we also have to manage their swallowing function. And then as we go on, we have to manage their slow, generalized neuropathy, with help them up harnesses. And we have a great physical therapy program for them and so forth. So we've really sort of opened up a whole different areas of study of the condition.
Yes, and I do need to give a shout out to Help 'em Up Harness, and I did a Facebook Live with the maker of Help 'em Up Harness, because that to me has been a lifesaver in 2 of my dogs, my Duncan and then my most recent Sam, who had spinal lymphoma. Saved me. So, like I tell everybody, I don't get paid by them, but I should, because I love them so much.
Yeah, and what they should be fitted properly, those Help 'em Up, and they can graduate from the one handle to the 2 handle. But we love those Help 'em Up harnesses. They're great for the dogs and for the people.
And for the people, for sure. So the larynx, just in general, for everybody to know, is just kind of like door flaps, right? And so breathing in, breathing out, we need them to open and close. So there are, since it is geriatric onset, the pets are older usually that have this disease. So when you're considering surgical options, can we talk about the different surgical options? Because I'm most common with the tieback, and that is when my boy Duncan, when he got it, he was 10 and a half, and he started to have that stridor, that breathing difficulty, not where it was an emergency. I think I probably could have even waited longer. And I want to ask about that, like when should we do it? But I did the tieback surgery. So can you explain like that to everybody?
Absolutely. So there are a number of different techniques, and there's certainly variations on the basic tieback technique. And first of all, the average age of this condition is about 11.3 years. So they're old dogs. Sometimes we get them at 8. I think the youngest I've ever had is 6. And it's different from the congenital laryngeal paralysis, completely different disease. And sometimes we get them up, 13, 14. Yeah. And as long as they are healthy, in other words, as long as they're lungs are healthy, their heart is healthy, and their blood work looks good, there's really not an indication not to do the surgery, because it's a pretty good, unless of course they've got mega esophagus, but I'll get onto that in a minute.
Okay.
So what we evaluate is typically that I actually do a CT scan of their whole body. Sometimes they have splenic masses and things, but their general health, as long as that's okay, then I try to work out how frequently they regurgitate or how frequently they throat clear. And now what I'm doing is I'm putting all of my patients for a couple of weeks before surgery, I put them on omeprazole and cisapride. And omeprazole is a proton pump inhibitor that will, and there are probably other drugs, Dr. Robertson will probably can suggest other drugs as well, but that's one that will, make the stomach contents less acid. And then cisapride is what we call a prokinetic agent. In other words, it keeps everything moving in the same direction so that they're less likely to regurgitate or even reflux from their stomach into their esophagus. And then we booked them in for surgery. And the different types of surgery, first of all, if these are the two flaps of the larynx as you're looking into it, normally when a dog breathes in, if he's not paralyzed, they goes like that when they breathe in, and then it relaxes. That when they breathe in, and then it relaxes. And if they're running around the backyard and they're running around at full speed, then it's just open when they're in and out.
Oh,
when
interesting.
When they're paralyzed, what happens is that they can't open it up, and they can't shut it either. So when a normal dog is swallowing, it goes like that too, so that all the food goes into the esophagus and not into the larynx. So when they're paralyzed, it just sits like this, and they can't shut it when they're swallowing, but they do have their epiglottis, which helps cover over that. But they can't shut it, and they can't open it up when they're breathing in. So what happens is they're flaccidly paralyzed. When they breathe in, they sort of suck it together like curtains when the breeze is going out through a window. It's like curtains through a window. They suck it together and relax, and that's when they can asphyxiate. So what we do is we go in and we tie just one side back. It's usually the left side, but it can be the right side. It doesn't matter. But you don't want to tie it back like this, because that'll make it too open. You just want to tie it back like that. And that's usually the surgery that's most commonly done. There is another surgery that I do, which opens up just the bottom of it, not the top of it. I can't do that with my hands so well. And I do that for dogs that have really bad esophageal dysfunction, and that's through a ventral laryngotomy. It doesn't give them as big an airway, but it's a little safer as far as aspiration pneumonia goes. But what we found in the literature, the percentage of aspiration pneumonia has been up to 24%. What we run at now is about 8%, and that's because we're not doing the tieback really dramatically, and also we're putting them on these agents that promote, esophageal emptying or gastric emptying, everything moving in the right direction away from the esophagus and the larynx. And so we have about 8%, and most cases of aspiration pneumonia, and it's all about teaching the owners what the first signs of aspiration pneumonia is what they are. And they are lethargy, in other words, the animal's dumpy, and they go off their feed. And with a Labrador, you notice they go off their feed, and so they become inappetent. And then they run a fever. And a lot of my owners, I'll get them to get a thermometer and dedicated for the dog, because at my house I could never remember which thermometer was for whom, so my children never let me take their temperature, so because they don't know where that thermometer had been. So a dedicated thermometer, and if they have those three things, we go to their local vet, their normal veterinarian, get some chest x-rays, put them on antibiotics, a bit of coupage, and they're fine.
Okay.
Every now and then you'll get a massive aspiration event, which will be fatal, but it's very rare.
Right. So you were saying that so like for my guy Duncan, right? Some people said I did it too soon. I should have waited. And for me, I just didn't want to see him get worse, and he wasn't regurgitating too much. Like I think I probably did it sooner than anybody else.
Yeah, there are pros and cons. First of all, with me, it depends on the time of year. So if we're coming into summer, I recommend, even if they're only on, even if they've still got a little, what happens first is the left side goes completely. And then on the right side, you'll start to see these fasciculations.
That's what he had.
Yeah. And that means it's about to go, So, and it's always bilateral in the end. So if it's coming into summer and the worst thing is, of course, if an animal asphyxiates at home or on the way to the vet in an emergency, and these guys can become emergent. So if it's coming into summer, I will recommend tying them back when you start to see it going. And it also gives the dog more time to adjust to, the fact that his anatomy is a little bit different now. Right. But if we're going into winter and it's just starting to go on one side, I say let's reevaluate him in a few months' time, maybe in the spring, and read up as much as you can. I give them some handouts. I have actually quite a few handouts that I can make available to you if you like.
That would be fantastic, because I know we have a lot of people are watching with this. So how old has been the oldest dog that you've done a tieback on?
20.
No. What kind? I love it.
It was a Labrador called
No.
Yeah.
Man, this is amazing. I love that. Oh, what was his name?
Charlotte, her name.
Her name. Oh my gosh, that's lovely. See, that's where I think a lot of people get a little concerned, is at the age. And Dr. Sheila Robertson and I did a Facebook Live a couple of months ago on how is my dog too old for anesthesia? And probably the most viewed video that I've done so far. And I like you say, if everything else is okay, then is this a very intense surgery? And I know mechanically it's a little tough. I could never do this. This needs somebody with a lot of letters and specialty after their name. I like, there might be GPs that are comfortable. What do you think?
No, so I would recommend that you get a board certified surgeon to do it. The normal tieback, it's done a lot by feel. You have to know the anatomy inside out. Yeah. Now, I can see that in some of the comments here, people are talking, Danny is talking about the BDEAP surgery, and that is the ventral laryngotomy that I'm talking about. That is more complicated. I know Ken Sabnaga does them. I do them. There's a few people that do them. And I just want to point out that with the tieback surgery, I still allow swimming. We've done a study which has shown there's no increase in the incidence of aspiration pneumonia after tieback. The only thing is that they mustn't dive below the water. And in fact, swimming and wading so I don't want them to dive for objects in the water. Okay. But they can go swimming and wading, which is wonderful physical therapy for their polyneuropathy. Yes. And in fact, it's part of the physical therapy protocols that we recommend afterwards. But I do recommend that we have that you get a board certified surgeon to do this procedure.
Yeah, this is special stuff, right? And so it's worth it. And I had Dr. Diane in Southern California. She did my boy's surgery, and I'm Who was that? Who was it? Diane Craig.
Oh, okay, yeah, good.
Yeah,
good.
And so she's in Southern California. So shout out to that whole team, because I was the worst patient mom. I was he did aspirate actually after he vomited after surgery and just wasn't feeling well, and so he aspirated a little bit of that, but he recovered like a champ. And they sent me pictures; they were wonderful. And I'm going to get to food in a second also, but he did end up developing maybe a year or so, 2 years maybe later, the polyneuropathy, and it was a toe drag that I first recognized. So a little knuckle of one toe, and it was in the sand. I was like, "What's that?" Or you might hear it, right? So if people hear it on the cement, they can hear it. A little. What's that toe drag? And then it got worse. He would just collapse almost. And I think if we have that degree of polyneuropathy where it's already that they're collapsing and they're dealing with massive mobility issues, do you think it's wise to do the surgery, or it's kind of like that's
we very rarely see that because the laryngeal paralysis precedes the neuropathy. Well, they can, I think about 20, just below a third, about 29% of dogs will have evidence of the neuropathy at the time of their laryngeal paralysis, but it's very mild, and it seems to lag behind the laryngeal paralysis. So
that's right.
Yeah. I mean, obviously, if an animal has mega esophagus or is not ambulatory, then they're not going to be good candidates for tieback.
Right. So let's talk about the megaesophagus, because that's something that I hear a lot about. And so, so can you just explain what big old esophagus means, and why is it associated with this, or not, or what?
So what we have is we have 5 grades of esophageal dysfunction. So we have the fact that, first of all, it might just be, normally when a bolus of food goes into the esophagus, it goes very quickly, amazingly quickly, down the esophagus into the stomach. A grade 1 is when it just goes more slowly.
Okay.
A grade 2 is when it goes more slowly, and it might stop for a little bit, but there's no retrograde movement.
It's like when I take my vitamins. Like they feel like they stop along the way. I'm just saying.
Yeah, probably. And then a grade 3 is when it goes slowly, and there might be a little bit of retrograde movement as it's going down. A grade 4 is when it's just all over the place. There's not really a good synchronous movement, but eventually it goes down. And then a grade 5, we actually don't do a swallowing study on the grade 5s. The grade 5, it means they've got a mega esophagus, just one big esophagus that is not very motile at all. So that's why we give them, we do a whole lot of things to help feeding post-operatively. The first thing we do is that when we've done our esophograms or our swallowing studies, we found that feeding large kibble is better than canned food, is better than water. So large kibble, and we used to say, don't let them gulp their food, but actually, sorry about the pun there, but actually it's really good if they eat their food quickly, because that stretches the esophagus, a big bolus, and that initiates a contractile wave. So it's great if they eat their food quickly. Large kibble. What's really important is to not let them drink a lot of water at once. So you know how labs, they go outside, they come back in, they either go to the water bowl or the toilet, and they lap for 30 minutes. You can't let them do that. You can't withhold water from them, but you just have to give it to them in intermittent periods during the day, rather than let them lap a whole lot at once, because that will make them regurgitate.
And there's wonderful bowls, the slow bowls, that have like things in them to let them not like lick so fast.
Yeah, and they're for eating. Yeah, but we want them to eat quickly, but we don't want them to drink a lot at once. So no gorging themselves on water. So that's really important.
Now, what about raising the bowl? Sorry to interrupt.
So then we did a study, and we had the bowl on the ground, and so we did a swallowing study. So we're doing fluoroscopy. It's like a moving X-ray. We're looking at the food going down the esophagus. We had the bowl on the ground, we had the bowl at shoulder height, and then we had the bowl at an inclined plane. And and we looked at esophageal transit time, how long it took for the food to go down the esophagus, and also the amount of esophageal reflux. In other words, when it goes from the esophagus back into from the stomach back into the esophagus. And we found, first of all, there was no difference between eating on the ground and eating at shoulder height. Okay, no difference in esophageal transit time or reflux. When they ate at an inclined plane, it was really, it was a little bit better, but it was only better in about 50% of the dogs, and the rest were better on the ground. So I think it's and there was no difference in esophageal reflux. So what I do, I used to say to people, elevated feed, inclined plane feeding, like, on the stairs, so that they're almost upright when they're eating. But now I just say to owners, work out your best time. Shoulder probably isn't the best. Shoulder height probably doesn't make any difference, but either feed them on the ground, and then feed them when they're sitting down, and you're feeding and holding their bowl so that their head is higher than their stomach.
I got it.
And work out which is the best for them, because it seems like it's more of an individual thing.
Yeah. So Dr. Craig, she said, just feed on the ground. And so many people said, elevate their bowl a little bit. And so she's like, no, feed on the ground and big old kibbles. And my boy had zero problems with that. Now he drank like a water buffalo. I have videos of him just naturally, he would stick his schnoz in the bowl and suck it up like a lab. And it was just like, and then he would lift it up and just drool it all. And I was nervous about that. And so I got this bowl that had some things in it to slow it had a little thing that floated so that way he didn't suck it up so fast, and that helped. Right. But so now because we got some great questions coming up, but let me just ask you about, I know we're going to ask this. So what about though the polyneuropathy and the exercising, and to like, when should we start that? What are some good advice?
So what we do is we have developed, and in fact, just before I left MSU, we were going to start a study, and then then I decided to leave. But we what we found that has really helped, because we're going to do a study with acupuncture, because a lot of clients have told me that acupuncture really helps, and I'd like to, I wanted to validate that or not, or to find out what was the story, but we never got that done. But what we have found out is that that a physical therapy program really helps. And Dr. Sarah Schull at Michigan State University worked this out with us, and she's been really good at working with the GOLPP dogs, and she does all the rehab and the physical therapy. And we look at several things. We look at strength training, we look at balancing, and then we look at we look at balancing and awareness of where their limbs are in space, because what they lose, if I shut my eyes and I put my hand up there, I know my hand is up there because I have a whole lot of receptors in my muscles that tell me where my hand is, and I know it's right there. But those receptors are the first to go in GOLPP dogs, so when they're not quite sure where their limbs are. And so we do exercises like cavalettis. So they actually have to look where they're placing their limbs. And we usually have a treat at the other end, so if they're not trained agility dogs, which many of them aren't. And so we have underwater treadmill for strength. We have sit to stands. We have we do side steps and back steps. We do cavalettis. A lot of sort of transition from hind leg weight to front leg weight, and then slow walks, again for getting moving, because a lot of these dogs have got a bit of arthritis as well.
Yeah, I did it all. I even did acupuncture with Dunk. We had somebody come once a week. I said, you know what, I'm going to do it all. Little bit of acupuncture, a little bit of prayer. Nobody's disproven that yet. So
I'd love to know. I'd love to know if it works.
I would love to know too, because I was lucky enough to have somebody that could come to the home and do that. But I had Cavaletti, like I built my own in the back so I could, do it with him and whatnot. So that was great. And so, with my boy Duncan, he actually ended up, I made him an angel because of heart disease, heart failure. So it was not his laryngeal paralysis. So I am so glad I did the surgery. Yeah. And I know so many people are nervous. I want to hit some of these questions. What were you going to say?
I was just going to say that, it's these dogs, these 11, 12-year-old, often Labradors, but whatever, they're members of the family. And, often the kids come in, it's a big family thing to come in. And if the dog is otherwise completely healthy, it's just difficult to condemn a dog just on the basis that, he can't breathe. And when they do so well, typically after surgery.
Yes. Now, I know somebody did ask, since we're on this topic right now, if somebody can't do surgery, whether they're not near a surgeon or they can't afford it, or there's other problems, right, going on with the pet. Are there any medical options to do besides the cisapride or the omeprazole?
So there's no, a lot of people ask me if there's any medical option for the neuropathy. And there isn't at the moment. At one stage, we were looking closely at some of the therapies for Lou Gehrig's disease, amyotrophic lateral sclerosis. It looks like this is more of a Charcot-Marie tooth disease, and there are some experimental drugs in those horrible diseases as well. But at the moment, there's nothing we can do to limit the polyneuropathy. But the physical therapy program, whether they've had the Tieback surgery or not had the Tieback surgery, is really beneficial for them.
You're right. Just because we can't necessarily fix this, we can help slow down the back end issues.
And obviously environmental control, making sure they're not out in hot weather and everything like that.
Right, and that's why the surgery in the summer, right? So we see so much of that if they're hot and whatnot. So we have got a ton, North Carolina, everything. So
I know people from everywhere here.
Everywhere, and thousands will watch this. Only not everybody who's watching it right now are the only ones. So we're going to have great feedback. So we've got Rochester, Michigan, excited to see the specialist in Michigan as her 9-year-old lab was recently diagnosed. So a lot of times it is either not necessarily diagnosed with a GP or suspected, and they go to get a diagnosis. Because I don't know if I was, when I was in general practice, skilled enough to get that anesthetic plane just perfect enough to diagnose. Because is that how you diagnose? You
Well, what we do is we have them under a light plane of anesthesia, but we always use a respiratory stimulant, doxapram, to make them take deep breaths, because otherwise it can be overdiagnosed as well. So there is, I mean, we have a whole upper airway exam form that we do, which I'm anal about, but
I love it.
So it's quite involved, but
I would suggest a specialist like diagnosing it. Like I think your GP could easily. Or
I don't know if I know my students out of Michigan State, they're pretty good at picking up
this I like
disease. Yeah.
All right. My UF friends need to get on this. So now actually you said something that reminded me of Dr.
Well, you've got Kat Ham there now. She's
right. Okay, you're right. So what about Doxapin, the drug? What are your thoughts on that? I'm glad.
Okay. So a lot of people talk about Doxapin as an anxiolytic sort of agent, and there is a study coming out. We were talking about it in the Veterinary Specialty Surgery Society a few weeks ago on our listserv, and there is a study coming out. I can't remember who's putting it out now, showing that there's no effect with Doxapin as far as no effect on their respiratory function, at improving their respiratory function, which is unfortunate.
Okay. That is unfortunate, because I know a lot of people listening try that, especially if they can't do the surgery. And I'll say I put Duncan on it first, and I saw no difference. And I was like, nope, he's going in for surgery.
I see some people saying hello. Like
I know people know you.
Hi.
I love it. Yeah. So all right. Looking for to learn about meds. So we already did that one. Greetings from Morristown. 11-year-old dog there. So, 12-and-a-half-year-old Great Pyrenees.
Well, here's one. So somebody asked, Kevin White asks, on the subject of throat clearing, all dogs clear their throat on occasion. At what level frequency does the throat clearing in a geriatric dog become a cause of concern? That's a really good question, because they do. There's nothing wrong with a dog, going out eating some grass, hoiking up. In fact, I think dogs probably normally vomit about, once a week anyhow.
I agree.
This is a fairly consistent throat clear. And what happens with these guys, and it's a gradual onset, but it is persistent, and it's several times a day. And it's not particularly a bad thing. What it is, we think, is saliva or fluid dripping down into the still innervated part of their trachea. And it's like when your drink goes down the wrong way or something, and you go, well, it just slowly dribbles down, and they feel it there, and they go, to bring it up again, and then they swallow it. So it's not a bad thing. It's just that it's a sign that something's not working right in there. And it actually takes a few months for that to resolve after Tieback for some reason.
Oh, so you're right. Actually, you never did that afterwards. I never thought of that.
And I don't know why that is, but after a few months, it seems to resolve.
That's so interesting. This reminds me of my Grandma Gardner, with her postnasal drip. And she rest in peace. I always clear her throat.
This is a human.
This is right. My grandma, human. Like she always cleared her throat for postnasal drip, and I like when Duncan was doing it, I'm like, you sound like grandma. There was now something I was going to ask about the. What about the voice? Like their bark.
So about 50% of the dogs will lose their bark before surgery.
Surgery, right?
Sorry, I should say their bark will change.
It's a croaky.
Bark. Every time I say bark. In the original GOLPP study, I would say, and how's their bark? And they say, their back's fine. No, we're here for the larynx. And so now I have to say, how's their bark? So
That was good.
Yeah. So in about 50% of dogs, and only 50% of the dogs, their bark will change. Now that's kind of unusual, and I put it down to the fact that with humans, if they have laryngeal dysfunction, like if they have bulbar onset Lou Gehrig's disease or something like that, one of the first things they will notice is a change in their voice. And the reason I think we don't notice it so much in the dogs is it's not such a refined mechanism. I mean, us vocalizing is a very refined mechanism compared to a dog barking. But it has changed about 50%. And then, of course, after the surgery, it will be altered and maybe non-existent.
Right. Yeah. Dunk was non-existent. So when he would be barking at something, it was a pathetic thing. Yeah. Yeah. Now, I was always worried that something was going to snap. Like, could that happen?
So the surgery itself, and this is why you've got to get an experienced board certified surgeon to do it. We put in 2 prosthetic sutures, and they're really robust as long as you've anchored them properly in the appropriate cartilages. If now some of the times the cartilages are calcified, and so as you tighten the sutures, they can pull out, but you will feel that immediately, and then you swear a bit, and then you go and do the other side instead. And so it's very unusual for it to fail if the sutures have been placed properly, for it to fail after you've tightened them.
Okay.
And, if they bark or anything like that, that's not going to have an effect because, the muscles aren't working anyhow.
Oh, that's true. I never thought, okay, that is true. But the calcification, does that come with age? And so is that maybe sometimes to do it a little sooner before it gets that bad, or they're going to get calcified anyway?
Well, that's an interesting question. I think with the type of needle I use, which is an MO6 needle, specifically because of these calcified cartilages, in most old dogs, they're calcified, but sometimes they're really calcified. So I use a specific needle that really sort of glides through the calcified cartilages very well, and it's all about tension. You just don't want to put too much tension on those when you're tightening them. But I don't know if doing it earlier. I guess if you could do it before they got calcified, sure.
Okay, that's me overthinking my GP brain. So I want to say, so Susan's from South Jersey. I lived in Vineland for a little bit. Got to do a shout out there, and I think we covered her questions. I'm just gonna look at both my Pomeranians. So what's the biggest dog you've done surgery on?
Newfoundland, probably.
Yeah, Newfies.
Newfies get this disease in a very similar fashion to Labradors because they're ancestrally related. There used to be the Greater Newfoundland and the Lesser Newfoundland, and the Lesser Newfoundland then became the Labrador, and the Greater Newfoundland became the Newfoundland that we know today.
I had no idea.
Yeah, because we've done some genetic work on both the Labradors and the Newfies as well.
No idea. I've learned so much right now.
But this question about the POMs, this is probably a completely separate condition. I'd be thinking more about either epiglottic retroversion or pharyngeal collapse, or maybe tracheal collapse with the POMs. You said they both had. So this surgery is not typically indicated for these little dogs with other upper airway issues.
Right. Yes. Okay.
There are other procedures we can do, but this isn't typically one of them.
Helen, good luck. Her girl goes in tomorrow, so I'm sure everything's gonna be fine. And keep us posted. Oh, here's a great one. Moira says, Moira, I want to make sure I pronounce that correctly. A dog with Cushing's a candidate.
Absolutely.
I was going to say
if it's controlled, and I mean, even if it's not controlled sometimes. The only thing that we worry about is, of course, coagulopathic problems.
Yes.
So as with any anesthesia with a Cushing's patient, and healing, of course, so you'd want them to be controlled if possible, because with high level of corticosteroids, they will take longer to heal and may be more susceptible to infection. But that's pretty straightforward. Many are Cushing.
Yes, many a cushioning. Yes, my boy Duncan, he couldn't, his platelets were bad, so he as a normal Doberman thing.
Yeah.
So Mintaka asked, where's the best way to find a surgeon? And we put in a link already. I've got little helpers behind the scenes, so we put in a link to find a good surgeon. And then, hello from Massachusetts. I found the support group for owners for one of, it was so helpful. So sadly, the neuropathy has done a number on her 14-year-old border collie. It's not just in her rear end, but also the front has been the biggest issues. So can it also go to the front legs too, this neuropathy?
It does. It does. Eventually it goes to the front legs, and eventually it'll get, if one of my most dedicated owners, they went through, all the help them up harnesses, and that at the end of the study, they will often donate their body so we can do histopath on them, and the phrenic nerves and the diaphragm and the intercostals were affected as well. So it is slowly progressive and will in fact, we've done some EMG and nerve conduction work on these guys, and even at the time of tieback, it's actually in the front legs. It's just not as noticeable. In fact, the nerve conductions are slower in the front than they are in the hind legs. So it just seems to present more as a hind leg problem. I think they're just a bit more sort of, wavy and wiggly in the hind. So people notice things like getting up onto the bed or getting into the car is really a problem. That's where the help 'em up harness is so useful.
It's so useful. So Andrea's got her 14-year-old lab Pumpkin getting evaluated for surgery later this month with Dr. Sadnaka.
Yeah, Kenneth. Yeah.
Oh, all right. She wants his opinion. Go for it, Andrea. I like it.
Yeah. No, that's
So Lauren's got a dog with nasal cancer as well and splenic nodules. I've considered him not a candidate for surgery. We were talking about, you did the CT to look for splenic issues and things.
Yeah. So that's so that's Lauren, isn't it? That's a difficult one, Lauren. So what we do CTs now, because a lot of these old dogs will have early splenic masses or a liver mass or an adrenal mass. And usually we can deal with them, especially the early ones. They're picked up incidentally. And so it's quite good. Sometimes we pick them up really early before they've done any damage. The nasal tumor with your guy is likely going to be the commonest nasal tumor is an adenocarcinoma, which is quite a malignant cancer. So I'd be a little bit concerned about that unless you think he's going to asphyxiate.
Right.
And if you think he's going to asphyxiate, then it might be worth, getting it. It's certainly, the surgery is an in and out procedure. We can do this. Sorry.
It's all right. Well, we didn't touch on this. It isn't a very difficult procedure on them, right? It's not like we're opening their abdomen and blood is going all over.
No. And so in fact, it takes me, can you still hear me okay?
Yes.
Yeah. It takes me about 30 minutes to do a tieback, and that's teaching as well with an intern or resident. So we're in and out very quickly, and we'll often send them home the same day now.
Get home and okay, I like this. So Kayla's got a dog that hasn't been formally diagnosed, but her GP is suspicious, and he'll be 10 in June, competing in high-level nose work competition, hiking and walking, swimming frequently. So definitely,
yeah,
I would maybe
that's
go
okay. I've had a number of agility dogs. They tend to retire after the surgery, but I still let them swim. I just don't like them diving, But most agility dogs that I've done, and often it's sort of Australian Shepherds and Border Collies and things, but they retire after the tieback. Well, they've often retired before the tieback.
Like the geriatric, right? Like, maybe a little fun in the backyard, but let's not go too crazy, right? Like, let's give them some time. So what about stem cell? Danny has asked, any studies on stem cell usage for GOLPP?
Not that I'm aware of, no.
Yeah, okay, good. A little bit, so we've been talking a lot about large breed. Labs, obviously, Newfies, my Doberman. What about small dogs? Do we know percentage of how much it's affected? This guy's a little Chihuahua or mini poodle.
So no, we don't see it in Chihuahuas. We do see it. Probably the smallest dog that we see it regularly in is a Brittany Spaniel.
Ooh.
And I don't know why. There must be a modifying gene or something like that. But the Brittany Spaniel will get this. I mean, it's not very common. The commonest breeds would be Labradors, Greyhounds. We see them in mixed breeds as well. Newfoundlands, Australian Shepherds, sometimes German Shepherds, occasionally Borzois, and Brittany's and things like that. So, but Labradors, in our first study, Labradors represented 70% of the cases.
70%. Wow, that's a lot. Okay. Helen is from Hereford in England. I don't know if I pronounced that correctly, but she's 13. Her 13-year-old dog is booked tomorrow to do a CT scan before surgery. So good luck. Is it very obvious what it is? Very obvious what she has. Is there any reason for them doing this? Well, you already said we want to see if there's anything else going on. So I think that's a wise idea.
Yeah, because although it's pretty characteristic, especially if it's a lab and it's 12 or 13, and the larynx is paralyzed. But there are other things that can cause laryngeal paralysis. And so, like, for example, a thyroid tumor, the thyroids, run right along the recurrent laryngeal nerve. And I've seen a number of times the thyroid tumor is causing laryngeal paralysis. And so it's a slightly different, it's a more spastic paralysis, which reasons I won't go into. It's just a different, there's one nerve that innervates another part of the larynx. So it's a different type of paralysis, but people won't pick it up. And so, you've got to rule out thyroid tumor. You've got to rule out any tumor from where this nerve comes off in the chest. So it could have a tumor in its chest that's affecting the recurrent laryngeal nerve as well. So it's absolutely, and CT is by far the best imaging modality we have for this region. We're not looking inside the brain for MRI, and it's much better than radiographs. It's much better than ultrasound. So, and then, we just pick up incidental things sometimes in the abdomen.
Yeah.
So I'd go for it, Helen.
Go for it, Helen. I like it. So Kelly, 13-year-old Labradoodle with a history of IMHA at age 9. She has splenomegaly, sluggish gallbladder, hind end weakness, scared to do the Tieback, otherwise healthy, full of life still. Any recommendations for her? And thank you for this video.
So I think, if her blood work's looking good, looks like you've already had her abdomen worked up. And, as long as there's nothing, if she has been diagnosed with laryngeal paralysis and it's an accurate diagnosis, there's and she's clinically affected, she actually has trouble, she has stridorous breathing, I would recommend the surgery. Yeah,
it's almost like night and day for my boy when after he recovered from surgery, which wasn't very long at all. I mean, he was out there running around like a new man and just so full of life and energy. And I think that's what most people report, is that they can breathe again and they can have so much good energy. So Andrea, almost a 14-year-old lab with noisy breathing when she gets excited, mainly. And when they go on their walks, her bark sounds a little different at times. Occasionally, I can hear a wheeze when she barks, but she's generally clear. She doesn't clear her throat and doesn't seem like she's having trouble breathing. I'm hoping that she's still early stages. Like you said, not everybody clears their throats.
Classical.
Yeah.
Yep, that's right. It sounds pretty classical. Yeah. Mm-hmm.
Yeah. Victoria, chronic ear infections linked to this? I haven't heard of that.
That's a really, really good question. Oh, it's a very good question, because the middle ear is connected to the nasopharynx, but via what we used to call the eustachian tube, we now call the auditory tube. And so very commonly, in fact, when I do a complete upper airway exam, I always do an otic exam and evaluate the middle ear with CT, because especially in brachycephalic breeds like French bulldogs and pugs and things, there is a definite connection between middle ear disease and nasopharyngeal health, but not with these guys.
Not with these guys. Okay, but that was a good question.
Great question.
I know. I like this. Ooh, can tie out with a collar or a chain contribute or exacerbate this?
Oh, that's a good question. So when we did our first study, one of the questions we asked was, for both the affected dogs and non-affected dogs, have you ever used a choke chain or a spiked collar or any sort of, does he pull on the collar and so forth? And there was no difference.
Oh, so, no difference.
I mean, yeah, no. So I don't think it was the same in the non-affected dogs and the same in the affected dogs, the amount of usage of those types of collars.
Okay, so but could like a traumatic experience cause it? Like, okay.
The only time that you can get that I've seen is true trauma, like which is typically bite wounds, where you get bilateral. And I've seen it a number of times. Funnily enough, I've seen it mostly in Jack Russell Terriers, where they get mauled in the neck. I'm sure they started it, but they get mauled in the neck and see bilateral laryngeal paralysis. And that is the type of laryngeal paralysis that's similar to the thyroid tumor.
Okay.
So slightly different. It's more spastic. It's very severe. But I've never seen it from any sort of pulling on the chain or historically from what we could determine from that first study.
Okay, very interesting. So Benet says, so Dr. Stanley did not stop performing the BDEAP due to complication rate, ? I was told that when researching for my dog, that there's more of a complication rate. It didn't seem like there was complication.
No, so the interesting thing is that the BDEAP, which is this, what you do is you go in through the ventral part of the larynx and you remove the vocal folds and you lateralize them to the thyroid cartilage. It's just not quite as, it's a more complicated surgery. The aim of it is, well, first of all, it's a more complicated surgery, but how can I say this? It's probably not as effective as the tieback, as far as, they still have some respiratory compromise, but it's very mild. The reason I do that surgery is because we think that, and that hasn't been documented, but we think that it's a little bit less likely to get aspiration pneumonia on the dogs with very poor esophageal function. So when they have, a mega esophagus, which I hate to tie back those guys, but sometimes they're dying because they're asphyxiating. And that's when I'll do a ventral laryngotomy approach. Or they have a grade 4, they have really uncoordinated. So you put them on cisapride for 2 weeks, get them on their drugs, and then do the ventral approach. And the thing is, it hasn't really been shown that it decreases the incidence of aspiration pneumonia. But I think the more that we need to follow that out and look at that again, because it makes sense. Because what we have is when you have the larynx and it comes like this, or it's like that, and you do the tieback. Whoops, where are we? It's back in front in my thing, and you do the tieback. So when they swallow, they can't. That stays open. There is a structure that comes up called the epiglottis when they swallow it. It's a passive movement. It comes back with the base of the tongue, but that's a triangle shape and it's broader at the bottom. So if we open it up at the bottom like that, then it's more likely that the epiglottis will cover the bottom part. So that's why we do the BVAP.
Oh, so
it's
interesting.
For dogs with really poor esophageal function. Yeah.
Very interesting. You now have a fan. Somebody wants to know where you practice if they wanted you to do the surgery. So you're over in Michigan.
Animal Surgical Center of Flint. I've retired from Michigan State University and I'm working in Flint, which everybody knows about, of course, because of the lead. So bring your own water. And it's actually very sad. I shouldn't make a joke about it, but it's fine now, of course. But it's Animal Surgical Center.
Nice. And about approximation. This is hard to approximate the cost, but I was in Southern California. It might be very different up near you. What's about I would say anywhere from $2,000 to $4,000, depending on what you're going to do with the CT too, right?
Yeah. We're about 2.5 to 3.5.
Yeah. Okay. It wasn't too far off, right? Any surgical referrals in Northern California? Go to that list and look at the list. I was in Southern California. I'm trying to see. I think we've covered a lot of these. I hear so many of the hind end. Sorry. So let's see. Lori, 11-year-old chocolate lab, was not diagnosed with LP until she had major hind end issues. No noticeable breathing issues until just recently. panting heavily after a walk. Would a tieback help him, or are we just too late? Well, I mean,
so if he's having respiratory issues, like if you're worried that he's going to asphyxiate, then a tieback would probably be indicated. Right. But if not, and this is, I do think that sometimes it might be a spectrum of the disease where sometimes the hind end comes on more quickly, just like in ALS or Lou Gehrig's disease. They can have the spinal part can come on before the bulbar onset. The trouble is, I don't see that group because usually they'll go to a neurologist or internal medicine people. I just see the ones where they come upper airway first. So there could be, that certainly could be the case, though it has such a characteristic phenotype. In other words, they're so classic, their presentations, that I doubt whether we are missing that sort of cohort. Yeah.
Okay.
There's a question here about pyridostigmine from Lauren.
Oh, I missed it. Yes.
And that would be more for myasthenia gravis, and which is a condition, for the, so this pyridostigmine is an anticholinesterase, and the interesting thing about that is that when we did our first study, we actually tested all our dogs for myasthenia gravis, because that can also obviously cause esophageal dysfunction, and none of them were positive for it. So, I don't think that I actually haven't tried to use pyridostigmine for these conditions, but I don't think it's a cholinesterase issue. Yeah. As far as we can tell from the biopsies, it seems to be an axonal degeneration rather than a neuromuscular junction issue. I hope that answers Lauren's question. Yes. Yeah.
So I'm reading somebody who's asking about oxygen tanks and masks and having those on the ready, if you will. And I know that I'll often recommend having a fan nearby the bed of the dog just to help them not feeling so anxious if they have a respiratory issue, right? And
fans are great. Yeah.
Excellent. And I think as it messes with like the trigeminal nerve in their nose, and like it makes them not so anxious, if you will, and then because that's what happens, then they just start breathing heavier and things get edema forms, and it gets to a emergency.
Yeah, that's a really good point, because when they're paralyzed, their larynx is like that, and so they can move enough air in and out to breathe as long as they're not air hungry. It's right. Once they start going that they suck it in and close it. If they are breathing sort of just slowly, Dusty, in and out, then that just stays. They've got enough airway. So the best drug that we use is a deep sedative. I will heavily sedate them, acepromazine. Yep. Because about 20% of the dogs that come in for a routine appointment will decompensate, and so typically I sedate them and cut them the next day, or if not, then I'll go straight to surgery. But it's really sedation really, really helps these. But then if you're going to do that chronically instead of doing surgery, then you're just going to have a heavily sedated dog all the time, which is not a great quality of life.
No, I know. And I mean, having oxygen for an emergency situation is good, but I just hate to to be the backup all the time. I get nervous about that. I think.
And absolutely, even if they do have oxygen, and flow by oxygen is of limited usefulness. I'm sure it's better than nothing, or even an oxygen cage. But if they're physically obstructing their airway, even if it's 100% oxygen, they're not going to get anything down there, because their larynx is closing.
There's nothing worse to me than respiratory distress in a pet. Like when I see them in the emergency state, it's awful.
Awful. I had one client that was coming in to see me with a GOLPP dog, and he called. Oh, it was just awful. He called from the car saying she was having trouble, and she ended up dying beside him in the car seat. It was just. It was the most traumatic thing for all of us, for him, for us. I'll never forget it. It was just awful.
It's awful. That's it. When I go to help families in the home, if there's respiratory distress, I almost don't talk much. I'm just going to go sedation first. Like that's priority to me. And then I'm going to explain everything because I just want everybody calm.
This guy, yeah, and he just felt, he was
so you have guilt on it.
Just awful. Yeah.
Yes, by the way, this is the best info on GOLPP Sam has ever heard. So, and you are my longest, but because I could just talk to you forever about this, and everybody is so appreciative of this. And I don't want to take too much of your time. There's been so many great comments. Is there?
Should I send you these? Go ahead.
Oh no! What were you going to just say?
Should I send you these documents that I have?
Yes!
You can post them?
Yes,
okay,
I'll
send them to you afterwards.
Please okay. do. I'll post them for everybody. Everybody knows that GOLPP is just having to deal with this myself. It's been one of my I don't want to say heart diseases, but it's like my heart. It's my passion because we see so much of it, and it's a big community. I never realized it myself.
Yeah.
And I don't think I noticed it in general practice as much as I did until I started, with Lap of Love, and we just see so many geriatric pets, and dealing, being a part of the Facebook group. So there's a wonderful Facebook group that I know a lot of you are already members of, and we'll post that as well, and all that information. I feel like there was something else I was going to ask her because I could just talk to you forever on this. Is there any for research or place that, a donation to a cause that's looking into this? Because I just feel like that it could do so much more work and the efforts that you've put into this. Is there any?
Well, I don't have any more funded studies at the moment, but ACVS is always a good. The ACVS Foundation is always it's the American College of Veterinary Surgeons, and I'm a regent I'm on the board of regents of ACVS, so I can always keep an eye on the monies that come in there, especially if you say it's for GOLPP research.
Yeah. Okay, good. I think that would be amazing, and I think those of us have lost our dogs that have had dealt with it. That it's you know what? I just said dogs. What about kitty cats? Last question. Can't forget the kitty cat.
Oh. Yeah, so cats do get it. With cats, we know much less about it. With cats, you've really got to look for another cause, like lymphoma or something else that could be causing the paralysis. But there are times when we see it, they seem to be a little bit younger. In fact, their ages are all over the place. You can do a tieback on them. That's when I get my loops out, and I almost do it under the microscope. And they do really well. I think it's a completely different genetic condition. You don't see the polyneuropathy, but you do see this occasionally. You'll see it's more of a sporadic thing rather than a familial thing, I think.
I am going to ask you one more question because this is a great one. So when my boy Duncan, he had his tieback done, and then he had a oral melanoma, and I wanted to have it removed, and I was a little nervous because he's already had the tieback done, and I have a wonderful picture of the anesthesiologist looking down his throat with the tieback. And so, what about follow-up surgeries? Allie asked about a dental afterwards.
Yeah, so we get a lot of these questions, so I'm glad that's come up. So obviously these dogs might need dentals or little lumpectomies or melanomas or whatever, might need further procedures. And what I just say to the client is they just need to be intubated carefully, which as Sheila would say, all animals should be intubated carefully. But and then I know she's listening. But I know that. So what I say is, if your regular veterinarian, your referring vet, is concerned, get them to call me, and I can talk about what to expect. They're actually easier to intubate after they've been tied back, and once they've healed, there's nothing really that's going to dislodge that tieback, because not only, even if the sutures fail later on, it's all fibrosed, it's almost not ankylosed, but more almost like an arthrodesis, and it's almost fused, I should say, in that position.
Oh, I love it. Okay, good. All right, good. So listen, one day I hope to meet you in person and buy you a treat on all of us. I know. In general, I can't wait to meet people, but to meet you specifically, and I think I'm going to give you a big hug from all of us on this group and those that are watching. This has been so helpful for people, myself, and thank you so much for all of your hard work for this disease and all the things that you're working on. And I was really blessed to have you on here. Yes, and thank you, Sheila. Sheila, who's out there, who helped organize this. Couldn't have done it without her. And all those that see you are definitely lucky to have you with taking care of their pets.
Oh,
and so,
you.
yeah, awesome. Well, thank you so much, Dr. Stanley. I appreciate it. Great. Bye.
Okay. Bye.